Healthcareonomics, changing healthcare by changing the way you think about healthcare. Hi, everybody. Welcome to Healthcareonomics, where we're here to change healthcare by changing the way you think about healthcare. I'm Dr. Kevin Wacasey, the host of Healthcareonomics, and this is episode 5 of Healthcareonomics for Employers. We're being brought to you by YouTube across several platforms, including YouTube, as well as the iTunes and SoundCloud podcast network. And we're also being brought to you now by Mike Church's Crusade channel, a very important avenue for you to hear libertarian ideas. And Mitter Church, the King Dude, as he's known to his listeners, I've been listening to Mike for years, has graciously offered to host Healthcareonomics on the Crusade channel. And you can find that at crusadechannel.com. Links are below. My special guest today is Curtis Cannon. Curtis is with Access Recovery in Birmingham, Alabama, where he is an employee benefits specialist. But Curtis has quite the history, quite the pedigree, if you will. We're going to get into that pretty soon. Or right now, we'll get into that. So, Curtis, take it away. Tell us a little bit about yourself.
Well, first, thank you for having me. I actually started my career at Blue Cross and Blue Shield in marketing and sales for large companies, typically 1,000 employees or more. Did that for a number of years, 13 to be exact, and I really just got tired of, beating the pavement, and also having to fight with the employers about those double-digit increases and trying to explain my way out of that. And it just became one of those things where I wanted to move on and maybe try my hand at something better. So I moved into consulting. I did some consulting work for a local firm. Did that for a couple years and just really saw too many gaps in the industry to be happy with it. Decided to transition into something that I said, I need to create a business that fills all the gaps. Everything that I see missing in our industry, I need to maybe do something about it. So I started Access Recovery and just really attacked efficiency and effectiveness.
So you were with Blue Cross Blue Shield for 13 years. So this is one of the reasons that I wanted to talk to you, because you've kind of been there and done that and seen everything from the inside of the beast. So tell us a little bit about your time there at Blue Cross and Blue Shield and what got you started down this path.
Right. I tell you what, we're kind of like the IRS, right? Everybody's interested to know what the inside guy knows, right? So
yeah, right.
We had this, you have this reputation where, cost is always attributed to the carriers, which in many cases it is,
Yeah.
My time there, I spent a lot of time trying to back out of a room of CFOs and controllers that wanted to know a simple question. Why are we experiencing, 17, 18, 20% renewal increases? And so in my estimation, I always put it on, bad behaviors of employees, which is, if that's not shameless enough, I don't know what is. But, we had a long run of, making a lot of money, a lot of the top C-suite guys, a lot of bonuses. So to me, that's what played into some of that, to be honest with you.
Now, were you saying that every year after year, you would have to go in and have these discussions? You were working with large groups, right? Over 1,000 employees, typically across the country, right, if I understand correctly.
My largest group had 90,000 employees.
Wow.
And almost 200,000 lives. So they had locations all across the state. Obviously, they're a Fortune 500 company, but I tell you what, those are complicated conversations, to say the least. When those guys want to know, they're bringing in the national big box brokers, and they're asking some really tough questions, as they should. Yeah. And I tell you, and they'll trade out a carrier like changing out underwear. I mean, it's not a big deal for them to change. So.
But now I'm kind of curious, and this leads to the obvious question for me, is that we often hear about how, well, I am, my health insurance is cheaper through my employer because there's so many people that are getting health insurance. And yet you're saying that even with these groups of 10, 20, 90,000 individuals, 200,000 covered lives, you're saying that they were having 17, 20, double-digit premium increases year after year? Is that right?
Yeah, easy, because the more people you would think, I think the common person may believe that more people share the risk. Well, more people, more risk. Okay, if they're not If the assets are not being managed properly, and if a lot of the claim spend has a lot of fat in it, there's no running away from double-digit increases, especially post healthcare reform.
Right.
That was
Obamacare, you mean? You post the ACA, the Obamacare, you mean?
Oh yeah. You know, multiple pages of required routine, physicals, a lot of extra paperwork, a lot of different mandates, and really it became health insurance reform, not healthcare reform, which I don't think people know the distinction. So
absolutely. I point that out in my first book, The Guide to Buying Health Insurance and Healthcare, that Obamacare was about health insurance. It wasn't the Affordable Care Act. It was all about health insurance. There's very little in there concerning healthcare.
Right.
But let me ask you this. So you're telling me, so you've now blown away the myth that larger pools equals decreased money, decreased premiums for companies. So there goes that myth, and that's one of the big reasons why employer-based health insurance advocates scream that we should have employer-based health insurance, or health care they call it, but we should have employer-based health insurance because look at what a deal it gets our clients and our customers, their employees. You're saying not true at all.
No, not true.
But this leads me to my next question, and of those employees, I know it's got to be all over the place, and I know you can't give me a definite answer, but just give me an idea, if you would, of these percentages of of these premiums that you're talking about. What percentage, just on average, in any given employee, what percentage would the employee be paying versus how much of that would the employer be paying?
The typical split in the Southeast is about 80-20 or 85-15, 85 being what the employer would pick up, 15%, or 20 being what the employee would pick up.
Wow. So the employee is enjoying this health insurance coverage, and it's probably really good health insurance coverage. And by good, I mean, I ask people all the time, I'm like, what do you mean by good health insurance? And they go, a low copay, a low deductible, and a low premium. And I'm like, where do you think you get all that from? Who do you think's paying for all that?
Right.
And I guess they are definitely not having to face that burden of paying the majority of those bills. So these employers are getting strapped with 85% of health insurance coverage. And then on top of that, they're getting hit with 15-20% increases every year.
That's right.
Something's got to give. I mean, something's got to change.
Right. The thing that people don't realize is that, your healthcare expenses are, in many cases, the number 2 item on the balance sheet for a CFO. Yeah. Okay. And
after
it's the
payroll,
number
you
one,
mean?
After
the payroll. Right.
And after, and also too, it's the number 1 cause of bankruptcy for a lot of people. So when you put those two factors together, and you got a runaway train here, I think it's 17-18% of the GDP now, healthcare spending. It's out of control. So there's no real end to this, and I don't think there's, a lot of people like to think that the insurance carriers have a method or a model or a product that's going to save them. Brokers, I know for a fact they really believe that, because obviously it's commission based.
Yeah, but, sure. They're pushing it. Yeah.
There's no way you're going to solve a insurance problem with another insurance product.
Well, I've often said I would never pay my big brother $20. I'd never hand him a $20 bill. I might do it once. To go and buy my ice cream for me from the ice cream truck down the street. I might do that once. Right. I would only do that once if he didn't bring me back any change. If he said, hey, it was $20 for the ice cream cone. I'm like, yeah, they're usually a couple of bucks. What happened to the other 18? Well, we have our administrative fees and we have all these other things. And
that's right.
No, I wouldn't pay Peter to pay Paul for me. I'd just go ahead and pay Paul if it were me.
Right.
So let me ask you this. How much of a burden do you think, and maybe you can answer this, maybe you can't, but smaller employers, let's say 100, 200 covered lives or covered employees under that plan, are they facing the same kind of 15 to 20% premiums, or do those employers in general, again, not specifics, but in general, do those employers tend to share more of that burden with their employees?
You come to find that the smaller employees, they really like to try to take care of their employees and shield them away from the increases. So they will take on those increases. Now, here's what happens. They'll take on those double-digit increases year after year, but they won't give them a pay increase. And so they'll subsidize those increases with the pay that they were going to promise their employees. So it's a nightmare scenario for everyone. And not to mention, you get a couple of those hemos, I call them the hemos or the cancer cases on a 200-man group. It'll totally wipe out the budget. And I've seen it time and time again. So it's a death cycle for most small businesses. I just think there's no way out of this thing with insurance.
So what you're saying is that, okay, so you just blew away another myth for me. You just blew away another concept, and that is this, that I've asked people again, what is it about your health insurance? Because I operate a DPC practice, a direct patient care practice. I don't take health insurance, and trying to convince people to pay for their health care without going through their health insurance, it's a little bit like trying to sell, ice to, somebody from northern Canada or northern Siberia. They're just not interested in it. Or they don't think they're interested in it. So the bottom line is that when I'm trying to talk to people about this and they bring up, my health insurance, I ask them, what's good about your health insurance? And they give me the usual, the copay, the deductible, that kind of thing. And I'm like, yeah, but your premium though. Oh, my employer covers that. My job pays my premium. And they use their health insurance. They go to the ER for snotty noses and they just cover flu shots. They expect all this. And they don't understand when I point out to them, I'm like, look, I know you say your employer pays for it, and they do. They pay for the vast majority of these benefits for you. But don't you think if they didn't have to pay for that, they might be able to pay you more money in your pocket? They might be able to give you raises, et cetera. Do you ever think about that? Yeah. And, I'm usually left with a blink response that I always tweet about when I bring this up to people. They're like, I never thought of it that way. And I'm like, yeah, think about it. If the employers are facing these double-digit increases, which you can read about in any newspaper or any news article you want to find, if the employers are faced with that, man, imagine if they give you a 10% raise every year. What would that be like? So, wow. So tell us again, I know that you said that you got to a point where you got sick of this, you've had enough of it. So tell us when that was and what you decided to do about it.
Well, I started Access Recovery in January of 2018. And again, it was about effectiveness and efficiency. So the business model was to focus squarely on health plan audits. So we're talking about dependent eligibility verification. We're talking about plan document review. That's kind of where I started. I think that the core business function of what we wanted to do at the time. And then I later learned about direct primary care and how really 80% of the claims, if you think about it, not in terms of volume, 80% of the claims that come through the carrier were primary care claims, not the cost, but the volume. So we're talking about relatively healthy people getting, flu shots, just the regular, acute stuff, vast majority of claims, and you got insurance paying for that. All that markup and fat and fluff baked into that number. And I'll give you an example is that, if you have a 99213, let's just say that's an office visit CPT code that's billed out to the carrier. Blue Cross, they pay, let's just say, $92 for bill. They probably cut it down to 30 or something, and they'll say, hey, chase this guy down for the copay. But here's my thing. There's a lot of codes and CPT codes that are kind of, I don't want to use the term upcoded, but they're baked in a little extra fluff just to make it over the bridge to Blue Cross, because they know they're going to cut it. And these guys are not getting paid all their money. That's a whole nother thing. That's a whole nother argument. And so what happens is, you end up paying more for things that you can get a lot less through direct primary care. So once you start cutting out the middleman, and I know I'm preaching to the choir here, but once you cut out the middleman, you'd be amazed how much cheaper and effective and efficient the healthcare system can be. So I'm a big
healthcare,
healthcare,
right? Yeah, 80%, huh? 80% of claims are due to primary care. And as I write in that first book again, The Guide to Buying Health Insurance and Healthcare, to me, no primary care should be covered by health insurance.
Exactly.
Not for the vast majority of people. I mean, if you're truly poor and indigent, or if you're truly disabled, of course, then, we need some mechanisms to help with that. But for those who have commercial, private, employer-sponsored, or individually bought health insurance through commercial companies, why on earth would you be paying your big brother to go buy you an ice cream or a snow cone?
Yeah.
It doesn't make any kind of sense to me.
Would you buy car insurance for gas, oil, tires, wipers? I mean, that's essentially what we're doing here.
Yeah.
When we apply primary care under insurance, you're basically paying for things that you're going to use at a high volume rate anyway. So what do you think that's going to do to the cost? The more you use, the more it goes up. So, and
the very same people, the very same employees, who, if you were to rear end them on a side street, at a low speed, and it doesn't cause much damage, they're the people who are going to get out of their car and say, my cousin owns a body shop. We don't have to report this on our car insurance, do we now?
Right.
That's what they're going to say. Right. And yet these very same people will show up in the ER. I used to be an ER physician, so I know they would show up in the ER with their sore throat or with a cough that's been bugging them for 2 weeks. No emergency whatsoever, but they know they can get the care, and they didn't want to take off work. So these people who make, $20 an hour will come in after hours because they didn't want to take off half a day from work, and lose $80. And they'll end up spending $2,000 in the ER in claims. It's insanity.
And then, they get hammered on the back of it because Blue Cross didn't consider it, or any carrier won't consider it a medical emergency. They'll hit them with a deductible, make it major medical. So they get hammered on both ends. The employer gets hammered, and the employee gets hammered.
And the employer gets hammered by the fact that claim was filed by somebody who could have handled it anyway. So I think we've got this. So tell us a little bit about what Access Recovery is doing to alleviate this. You were talking with me when we first talked about what's going on in your home state of Alabama, and I found that fascinating, and I really love what you're trying to do in marrying up and getting DPC practices established. So tell us about that.
Well, I've just decided, when I found out about direct primary care, the initial fascination was the fact that when I did my dependent eligibility audit, and, we maybe identify 6% of that population being ineligible, they'd say, well, we have to remove these people from the plan. And the employer used to say, well, listen, these are our church members. We go to church with them. We know their families. So where are we supposed to put them? And so when I found out about direct primary care, I said, listen, here's a nice landing spot. Right? Yeah. They can have a nice membership, and they'll have better care than they would going to a traditional doc. So once I find out this place, they existed, the docs in my state existed, there were direct primary care docs, I reached out to each one of them, and I went and seen them, each one. I said, listen, this needs to be in the employer, in the local business community. All the employees and their families, they need access to this level of care. I know you guys are serving the community and doing a great job of it, but we need this to help get costs down and get better care. So I partnered with all of them. I just did a local TV show the other day in Alabama here called Talk of Alabama about the value of direct primary care and how can it save employees money and the value to employees. It's something that I'm a huge advocate of here of late, and I'm going to push it and promote it. I'd like to get a healthcare forum as well. As you know, there's a huge opioid crisis here locally in Alabama and really abroad. I'd like to start something of a healthcare summit for local businesses and physicians to talk directly without the middlemen in between the both of them. But that's on the way. We're working towards that.
Well, good for you. I appreciate that. Yeah, I think that. You were mentioning the other day that there's no DPC doctors. There are no direct patient care. And let me clarify this. Curtis says direct primary care. I prefer the term direct patient care. It doesn't really matter which is which, because what we're talking about, folks, is the being like every other business in the U.S., where a doctor doesn't take any insurance or any kind of third-party payment. Right. You just pay them directly. Now, the particular model that Curtis is discussing is where, and this is what I practice, it's more of a comprehensive care model where we do an annual fee and my patients can pay that monthly. But in exchange for the annual fee, my patients get a tremendous workup. We do an initial visit, lab work, and EKG for my patients that I do. And then they have me 24/7. I'm on call right now. If I get a call from a patient during this podcast, I'm going to have to answer it. It's, we're recording this in the middle of the afternoon on a Saturday. And I'm telling you, shoot, if I get a call, I'm going to answer it. And if I have to go see somebody, I'll go see them tonight or today if I need to. So that's the kind of service we're talking about. But you were saying in our previous conversation the other day that there's really no DPC docs south of Birmingham where you are.
Right. They're all kind of on the eastern side of the state and maybe in the northern area. But south of Birmingham, which Birmingham is located in central Alabama, it's right slap in the middle of the state. Gotcha. So half the state, there's no access to any doctors. And what I'm hoping to do and accomplish is to maybe recruit some of those doctors of just thinking about the value of transitioning to a direct primary care model. I've not talked to one doctor that was not interested in this. They literally hate their life right now. The way they're having to manage 2,500 patients, spending 7 minutes each with a patient.
That's right.
A waiting
they get
room
7 minutes each?
People.
Wow.
Yeah, that's
impressive.
Like a lot of time.
7 minutes, yeah. I thought it was down to 2.5.
I know that. So
if they even see the doc.
Here's what's beautiful about the model that I love is the fact that you can spend less than 7 minutes walking through the door and spend an hour with your doctor. It used to be in the traditional models reverse. You spend an hour in the waiting room. So
that's great. That's a great flip. I love it. Yeah, you flip-flop the arrangement. You flip-flop the time you spend in the waiting room with the time you spend with the actual doc talking with him or her. Yeah, that's a great way to put it. I'm going to steal that. I think I'm going to use that in some tweets sometime. So thank you.
Go for it.
Credit to Curtis already. Yeah, so to me, this is, direct patient care, direct primary care, whatever you want to call it. The idea of kicking all third parties out of the relationship between the physician and the patient is where we're headed. That's where health care is headed. It's where we have to head. And it's only natural because of the rising deductibles, the increasing out-of-pocket responsibilities. And what you were alluding to earlier about you can't fix one insurance problem by tacking on more insurance to it. I want to bring that kind of full circle and say that, for too long now, employers and employees have kind of chased the rabbit down the hole. They've been of the impression that, gosh, if I just pay more in premiums and get this lower deductible, this lower copay, wow, it's all going to be great. And I point out, I have this app called Dr. W's Equation where I point out that, and in fact, in my book, I looked at 10 different health insurance comparisons, and it's a very simple equation, very simple to use. The app is on the iTunes store and the Google Android store if you're interested. But this app shows you directly how much money you're going to spend versus how much money you could save. And in 10 different policy comparisons in my first book that I did, the bronze plan turned out to be the most financially advantageous in most cases, not in every case, and I go over the exceptions in the book, but in most cases, most people are wasting their money if they upgrade their health insurance plan. Not in all cases, I'm not going to say that, but in most cases you are. And I think employers are just as guilty of this as employees, and it's because of their employees. They're being held hostage.
That's right.
So let me ask you this. What's your approach then to a new client, a new employer that you want to solicit business from? How do you approach them and what do you tell them about yourself?
Well, what I do is I like to consider myself someone who scrutinizes the assets, the healthcare spending habits of that client. So I like to make sure that, to me, it makes no sense to buy another product, get another increased deductible, cost shifts in employees, because you're really not helping things when you increase a copay. Guess what's going to happen? That guy's not going to go to the doctor when he needs to, and you'll be looking at another ER claim. So my whole approach is let's stop for a moment. Let's take a very good assessment of what your health plan looks like. Let's look at where we're wasting money, where we're not using products that need to really, they're just hanging on. Nobody's using, let's just say Teladoc, for example. Why are we using Teladoc? We can get a direct primary care physician in here and he can see your patient unlimited amounts of time. They can call them at night. They can text them. So you have your telemedicine there. Don't pay for extra stuff. Not only that, let's look at how you can maybe have more of a drug screening program. Maybe you don't pay a third party to do that. Maybe your direct primary care physician can do the drug screening.
Yes.
I mean,
Yes, huge savings.
Huge savings.
Huge savings.
Not to,
and in
not
states,
to mention,
in states where Texas is not a state where I can dispense drugs through a pharmacy in my clinic, but there's only 3 states like that. The vast majority of states, including, I'm sure, Alabama, physicians can dispense medications for cheap, for dirt cheap to patients.
Absolutely. Yeah, drugs. I mean, it goes on and on. So to me, I think there's no scenario in which direct primary care doesn't add a lot of value to the employee and patient experience. For a number of reasons. So, and then with that, maybe you don't need the rich plan, the platinum level plan where you have a $10 deductible that's costing you an arm and a leg to maintain. But, it's really about education. That's really what we're having to do here locally, is educate employers and employees about direct primary care and the advantages of it. So, that's
absolutely.
kind of where I'm at now.
Well, I want to congratulate you because you're one of the few people out there, employee benefits-wise, that I've ran across, and this is, again, why I asked you on the show, is because I think you get it, and you're saying that, look, I want to help my clients save money, or I want to make money by helping my clients save money. And there's plenty of opportunity to do that within the healthcare and the healthcare coverage arena these days. Plenty of opportunity to do that. So you really stand out from the crowd, Curtis. I have to say. Well,
thank you. I think the main thing is, I think it's important to note that, and I'm glad you mentioned that being compensated based off of a percentage of savings, to me, that aligns your interest with your client. So they know that you're working just as hard to save them money as you are to get paid. So
let me clarify that. Rather than making it compensation based upon how much your clients spend, you're saying you're making your compensation based upon how much they save.
That's exactly right.
What could be better?
That's exactly right. So
Especially when you're
instead of me looking for products, I look for solutions.
Yes,
I look for ways to save them money, and the more I save them, the better it is for me. So we're all, on the same page.
The incentives are aligned. Well, Curtis, I want to thank you for coming on. I hope this isn't your first and only appearance, though. I definitely want to invite you back.
I'd love to be back.
We have lots more to discuss, I think, in the future. But in the meantime, you can check out Curtis with Access Recovery at accessrecovery.org. That's O-R-G, folks. Accessrecovery.org. The links will be below. Please contact Curtis if he can be of any assistance to you. My physician colleagues included in the state of Alabama who need some help or need some guidance in starting up their own direct patient care practice, give Curtis a shout. Maybe he can help you get some patients through your door quickly and ease that transition for you. Until next time, folks, I want to thank everybody for tuning in. Check us out again on YouTube, iTunes, SoundCloud, and our newest partner, our flagship radio partner, CrusadeChannel.com. Until next time, I'm Dr. Kevin Wacasey. Stay healthy. Now you can easily compare health insurance plans and pick the one that makes the most financial sense with the Dr. W's Equation app, available for Android and iPhone. And for more information on how you can save on health insurance and healthcare, check out my books, available now on Amazon, iTunes, and Nook. To help spread this message, please click the like button on this video. You can also subscribe to the Healthcareonomics YouTube channel and visit healthcareonomics.com.